Welcome everyone to the third in our winter quarter Northwest Geriatric Workforce Enhancement Center lecture series on geriatric healthcare. My name is Barbara Cochran. I'm the director of the DeTournier Center for Healthy Aging here in the School of Nursing, and I'm also associate director for the Northwest GWEC, or GWEC as we call it fondly. I'm very happy today to introduce Nancy Hooyman. She's asked me to keep it short, so I'll say she is a very nice person and one of my favorite colleagues. She is also a professor, very impressive, professor and dean emeritus at the UW School of Social Work. She received her PhD in sociology and social work from the University of Michigan. As dean for 14 years, the School of Social Work was ranked third out of 135 graduate programs by U.S. News and World Report. She is author of 8 books, over 100 articles and chapters. She's a well-known consultant and authority on social gerontology and multidisciplinary perspectives, feminist perspectives, and policies about elder justice. She's going to talk with you today about working with low-income and homeless older adults, and welcome, Nancy.
Thank you. Well, I'm delighted to be here, and hello to all of you who aren't in the room. Really thrilled to see the geographic spread of the people who are signed on. And we're going to focus today on a population that's often invisible and overlooked, both by the aging network and by homeless providers. And that is older adults who are homeless, and by nature, of course, then many of them are low income. So in terms of learning objectives, here they briefly are. And I have to say up front, I have a lot of slides because there's a lot of content I wanted to make sure people had access to after the presentation. I will be going through some of them fairly quickly so that we have time for questions and discussion, because I suspect many of you have experience working with low-income older adults or working with those who are homeless, and we want to draw upon that. In terms of what we'll cover, why is this topic so important? The growing rates of poverty, hunger, and homelessness, the 2 different categories or pathways to homelessness, the impacts that has on health and mortality, the gaps in our service systems, and again, it's gaps in both the aging network and in the homeless service system. What's happened as far as federal policy responses, what do we know about effective integrated care as a model that works with the homeless elders, and the importance of service-enriched housing models, and close with a call to action of steps that we all can take. So why this topic? Well, in many ways, if we think how low-income older adults are already invisible due to ageism in our society, and then when we look at those who are homeless, they are truly the most invisible. And the service system tends to focus on younger homeless, and as I say, the aging network often doesn't even recognize some of the needs of older homeless. And oftentimes they're not seeing the older homeless because they're not able or open or willing or have the interest or knowledge to access services. Of course, these days we hear so much about the social determinants of health. Those of you who have been in the field knew about the social determinants of health well before people started writing about them and recognized by the Affordable Care Act. But we increasingly see that housing is really a part of healthcare. In order to have healthy aging, however that's defined, housing is central to that. At the same time, elder homelessness has been increasing in recent years, in part because of the growth of the older population, but more recently because of rising poverty rates and increasing housing costs that are after effects of the Great Recession. And we see greater income inequality amongst older adults than any other age group. And yet, as I've already intimated, the needs of older homeless differ so much from those who are younger, and thus has great results in gaps in practice and policy. Just some quotes to share with you the importance of understanding the lived experience of those who become homeless in old age and what that must feel like. Again, in shortness of time, I'm not going to read these, but you can come back to them. So I'm going to just talk very briefly about the increase in poverty and the increase in hunger that we've experienced since 2009, and then move to talking specifically about the needs of older homeless. But certainly the increasing poverty rate is a factor in why we're seeing more older adults who are living on the streets or living in shelters. Poverty rate now is just slightly under 10%. In King County, it's about 9.3%. We did see an increase in poor older adults in 2010, and that was the first time that there had been an increase since the 1950s. Of course, we all know that because of the Social Security Act, that's been the primary factor in reducing poverty amongst older adults. But the Great Recession certainly had a negative impact in terms of poverty. And we also know, and those, again, you out in the field know that the statistics don't tell the whole story. That the official poverty threshold doesn't capture those who are considered economically vulnerable, who are living at or below 200% of the poverty line. It doesn't count the hidden poor, those who are living with relatives or friends or in long-term care facilities. And we also know that older adults are more likely than younger age groups to move in and out of poverty as they're aging. Older adults have a high likelihood of falling into poverty or near poverty for at least a year. And it's a rather high percentage of those aged 60 to 84 who will not have enough assets to weather unanticipated expenses or downturns in their income. Of course, the problems of poverty vary by state. California has the highest percentage of older adults with inadequate income for covering basic needs, even though only 8% are officially in poverty. But we're certainly seeing in Seattle the cost of living having an impact on people's ability to manage on fixed incomes. Unfortunately, I wasn't able to get a lot of data about Seattle, King County. Wherever I have been able to, I include it. And then for those of you who are not in Seattle, I apologize that I don't have, obviously I've only got national data and then in some instances what we're experiencing in Seattle, King County. So closely related, and then one of the odd things is that the poverty standard for older adults is actually lower than that for younger adults. The federal standard assumes that the cost of food and other necessities are less for older people than younger people, which I can see by the puzzled look on some faces makes no sense, since older adults spend more proportionately on health care in particular, but often on housing and utilities. So if the same poverty standard were applied as with other age groups, the poverty rate nationally amongst older adults would be 20%. And when health care costs are taken into account, the poverty rate is almost 17%. So again, it's always important to look beyond that official statistic of just under 10%. It doesn't capture the movement in and out of poverty. It doesn't capture that catastrophic medical costs can put, even for those who have Medicare, can end up putting someone falling below the poverty line very quickly. There is a new supplemental measure of poverty that does take account of current economic conditions, and it does take account of out-of-pocket medical spending and geographic variations. And when that standard's applied, the poverty rate is 15%. And again, the rate amongst older adults is higher than any other age group. So clearly there's a lot of different measures out there, but regardless of how it's measured, what we do know is more older people are in economic distress than 10 years ago. And they may be just above the poverty line, but again, some unexpected crises could throw them below poverty. So closely related to the increasing poverty rates are the growing rates of hunger. Nationally, almost 9% of older adults experience what the federal government calls hunger, which is food insecurity. But it's striking that that has increased. In 2001, it was 5.5%. And another 15% are at risk of hunger, even though many of them have incomes above the poverty line. Food Lifeline in Seattle estimates that about 14% of the people they serve are older adults, but they don't keep the data on age in all their interactions. So this estimate is based upon their appearance and this estimate. So it's a soft estimate. But I know every time I drive by people standing outside the food bank, I'm always struck by the number of people who appear to be older in that line. So we know the impacts of hunger in terms of negative health effects, and that being marginally food insecure does result in a person being physiologically older than their chronological age. And the research on food insecurity estimates that about 14 years older physiologically. In other words, in terms of ability to function, in terms of their overall systems, bodily systems. Risk factors for hunger: living alone, having a disability, being African American or Latino, limited income. But again, 50% of those who fall into what's called food insecurity do have incomes above the poverty line. Ages 60 to 64, being a renter and living with a grandchild, which is striking because it makes you wonder if the grandparent is going without food to be able to make sure the grandchild is fed. The program to address hunger is SNAP, the name for what used to be food stamps. It is of concern that 3 out of 5 older adults who qualify for SNAP don't participate. And I've identified what have been seen as the primary barriers to their participation. Certainly, stigma and perception of access being difficult are primary factors. So we've looked at poverty, we've looked at hunger, and now we'll turn to looking specifically at homelessness. And obviously, most homeless people are poor and most are lacking adequate nutrition. The definition of homelessness that's put out by the Department of Housing and Urban Development is lack of housing or being precariously housed. And that precariously housed is an important concept. It's not just someone who's living on streets or in shelters or in their cars, but also people who are living in temporary arrangements, perhaps sleeping on a couch of a family member or a friend, who are very vulnerable to ending up on the streets. And then some definitions that take account of the social psychological characteristics talk about homelessness encompassing disaffiliation and disconnection from social supports and traditional systems of care. When we talk about older homeless, it's important to recognize that the age criteria is 50 or 55. And that again is because someone who is homeless is likely to be 15 to 20 years older physiologically because of premature aging, chronic health conditions, functional limitations, and that premature aging is due to the harsh living conditions that they've undoubtedly encountered either across their life course or more recently. Older homelessness is increasing nationally. If we look at those who are living in shelters, it increased from about 19% in 2006 to 22% now. There is a smaller percent increase, only about a 5% increase after age 61, but that may be in part because average life expectancy for those who are homeless is between 62 and 64 years of age. Nationally, there's projections of increasing by 33% by 2020 and by more than 50% by 2050. In part, it's attributed to the increasing number of baby boomers. There are simply more older adults, so that means there's more who are likely to be homeless or precariously housed, and what's considered, and this is always these federal government terms, like those who are considered at elevated and sustained risk. Again, that some one event might tip them into being homeless. Here's projections of homelessness between 1990 to 2050. Uh, Then when we look at Seattle-King County, I talked to a number of providers. One person estimated that about 25% of those who are homeless in King County are age 55 and older. But it's so hard to get a count. Obviously, if someone's in a shelter, we can get a shelter count. But what King County so frequently uses is their annual one-night count. And I'm sure you're all familiar with that, where volunteers go out in the streets and at night and simply count bodies. Last January, the count was 10,047. But it's a visual count, so they're just looking and thinking, well, someone looks like they're older. When I talked to staff at DESC, the Downtown Emergency Shelter Center, which is the major provider of shelters in Seattle, they did have data that showed that 20 years ago, the average age of people in their shelters was in their 30s, and today it's in the low 50s. Again, some of those may be due to people who've aged in place in the shelter, and some may be the newly homeless that we'll talk about in a minute. And then when they've also said the average age of men is 51, women 52 in the emergency shelters, and in their day programs, the age is younger. And typically in the day programs, it's people who still have more potential for being employed, and they tend to be in better health, and they're not seeing as many older adults in the day programs as in the emergency shelters. So who are homeless older adults? And it's really important to recognize that there's two subgroups because there's different causes and different practice implications. The chronically homeless are defined by the federal government as those who've been homeless continuously for a year or 4+ times in the past 3 years that combine to equal 12 months. So 4 different episodes of homelessness in the past 3 years that would equal 12 months. This is the latest definition that was in the Federal Register in December. And I think this is the group that we tend to hear the most about and see more often when we're in downtown Seattle. But there's also what's called the newly homeless, or those who have just become homeless in middle or old age. And this tends to be highest amongst African Americans and, interestingly, lowest amongst Latinos. And the research on racial differences just questions, is that because Latinos are less likely to be accessing any services because of immigration issues and fears of deportation. But there's not an explanation for the lower rate amongst Latinos that's agreed upon. So looking at these two pictures, it's hard to say, is this for someone who's chronically homeless or newly homeless? Although we do know that men predominate amongst the chronically homeless, since it's so, maybe these are the chronically homeless. But I show these pictures just to capture, when we see someone, we don't know what's brought them to this point. We don't know what their life experiences have been. And we tend to make certain assumptions that probably always need to check out, because particularly with the newly homeless, it could have been a crisis, the loss of affordable housing being the most common cause in the Seattle-King County area. The chronically homeless are those who have truly aged in place on the streets. And it's estimated that 50% of the chronic homeless are age 50 and above. That's a national estimate. And that they've spent 15 or more years on the streets. And as I already mentioned, more single men than women. And I think we all know a lot of the causes of chronic homelessness, with the primary one being deinstitutionalization, substance abuse, severe mental illness, cognitive impairment due to alcoholism, limited social supports. All these factors are ones that we're familiar with, but really it reflects the accumulation of a lifetime of risk factors or a lifetime of disadvantage. And the largest percentage of older adults that we see on the streets are probably the chronically homeless. They have higher rates of chronic illness and functional impairment. And really, we look at the cumulative impact of adversity across the life course, and they simply have much, they're not as resilient. I mean, they're resilient in the sense that they survive on the streets, so that in itself is resilience. But if they become ill, if they require hospitalization, if they require surgery or treatment, they're simply less able to bounce back because of the lifetime accumulation of adversity. And they're much more likely than newly homeless to mistrust service providers and shelters, and it's harder to get them into housing, even when the housing's available. The newly homeless, many of the newly homeless have led what we might consider, quote, conventional lives, and I put that in quotes because who's to say what a conventional life is, but they're fairly educated, they probably have worked most of their lives, and they may have been in a fairly stable residential situation prior to becoming homeless. But then either due to a crisis, a trigger event, or a gradual slide, they've ended up as homeless. And the primary causes of the newly homeless are relationship changes and losses. Again, many of these would sound very familiar when you think about the older adults that you may be working with. Chronic illness and disability, with catastrophic medical expenses, cognitive impairment, loss of a job, so being unemployed or underemployed, lack of jobs to pay a living wage, and certainly lower likelihood of being able to return to work. But in the Seattle area and in most major cities, the most important factor is rising housing costs, rising rents, building closures or sales, redevelopment, eviction, home foreclosures. And the number of newly homeless has certainly increased as a result of the Great Recession and people who lost homes to foreclosure. And we know that more and more older adults are spending a larger percentage of their income on housing than they were 10 to 15 years ago, and this is carrying a greater housing burden, greater than 30% of their income, which puts people at risk if they have other major expenses. But again, in Seattle, it's the declining availability of affordable housing that's really more significant than poverty itself. This is an example of a woman who had lived in her own home for years. She decided to refinance her home and really got caught up in a scam where she had astronomical loan payments. Then the company that refinanced her home went under and she lost her home to foreclosure. And I suspect there's, even though the economy has improved, sadly I think there's probably still older adults, we know there's still older adults who are victims of scams that could mean the loss of their home. This is just such a moving picture, I think. I'm 97 and homeless, please help. It's just hard to imagine someone that age living on the streets or living in shelters. So I want to stop a minute and play a video, John, that was made by Senior Services. You may be familiar with it. It was made during, in fact, you may have helped produce this. You'll see. So it's a bit dated, but I like it because it captures the voices of the newly homeless, and I think really makes us aware that we may all just be one step away from homeless, that some trigger event or crisis could put us into that situation.
Click on the arrow to get it started.
Oh yes, thank you. I just go.
My name is Carol, C-A-R-O-L-E, and I live in Georgetown, and I'm currently homeless. There's more homeless seniors now than there was 5 years ago.
My name is John Walls, and I'm 56 years old. I was born and raised here in Georgetown. This is my home. It's been my home for all this time. I've always had a place to live. My whole life, I've always worked, and I've always had a place. And so this is really a big change to me. Yeah. If I had a little bit of a break, just enough break to give, that I could get my stuff together and I could get out of here. I'm hoping it's going to work out. I think it will. It's just been a long, hard struggle.
So before I continue on, I'm just curious of the people in the room, and I realize I can't see the others, but are any of you currently working with homeless older adults or seeing them in your practice, in your work? Could you talk to us a little bit about how you're seeing them?
Well, I work in hospice, and so one of the requirements for them to come on service is for them to have a home. So a lot of times it's our social workers kind of fight is to try to get them into some type of housing at the end of life in order to get them on the service.
You need to repeat that.
Yeah, so the example this individual shared is that she works in hospice, and of course for someone to be able to receive hospice services, they have to be in a home setting, or it's in some situations in a skilled nursing home or a hospital. And so that's a challenge with those who've been living on the streets to be in a house to be able to receive hospice. And that's true for home health care. Think about someone who's homeless, who's had surgery and really needs home health care, but if they're in a shelter, they have to leave the shelter during the day because shelters close down during the day. They simply don't have a place to rest, and they don't have a place to get home health care. So the concept of home is really central to some of our services, particularly at end of life or after an illness. Anybody else have an example? Yes?
Well, I work in a jail, so that's a
yeah.
big issue for a lot of our people. We have older people in the jail, some of them, not all of them, of course. But
right.
It's a big problem for people getting released after 20 years in prison or whatever it might be.
Yeah, so the example here was someone who works in a jail and sees homeless, a lot of homeless, and an increase in some older homeless, and then when they're released from jail, where do they go? They don't have family supports.
Some from being homeless too.
Yeah.
Living in the national park, old veterans and stuff like that, they get in trouble.
Yeah, it's we sadly are seeing aging in place on the streets and aging in place in prisons. Prisons simply not being really well prepared, or the correctional facilities, to deal with the healthcare needs of older persons.
Or the discharge planning and whatnot that they might require.
Yes, yeah, the discharge planning is a huge issue, and it's an issue then for someone who's been in the hospital. It's an issue as well. I mean, again, where do you discharge to? Okay, well, thanks for sharing those examples, and I hope everybody could hear enough of them, because they both capture some of the huge gaps in both housing and healthcare. John, why is it not? Oh, okay. What would we do without someone like John? Thank you. So the example of Carol in the video, we saw her walking toward an old van, and I presume from that that's where she's living. And this is certainly an issue we've seen in Seattle, is more people living in their cars, and the whole challenge of where the cars are parked at night, and whether church parking lots are available or shopping center parking lots. But again, these are two examples of women in Seattle who really had, quote, very conventional lives, but then lost their job. They had to declare bankruptcy because unable to sell their homes or manage a mortgage. And these are women who are living in cars in the Seattle area, who simply never dreamed this would happen to them. And I share these quotes because I think it's so important for us as providers to remember the different pathways and have more, avoid assumptions about alcoholism, other forms of substance abuse when we see when we see any homeless person, but to realize that it could be forces completely beyond their control that have resulted in their being on the streets. Homeless veterans, you mentioned the vets in the prison system and who had been living in the national parks. They're more likely to be homeless than older non-vets. And veterans are 50% more likely to become homeless compared to all Americans across all ages. Fortunately, there has been a push under the current administration to end homelessness amongst vets. And in talking with service providers in the Seattle area, the Veterans Housing Choice Voucher Program, their Section 8 version, has been relatively effective at getting people into homes. And service providers all said they wished there were that kind of housing choice voucher program available to all older adults. So while it's still a huge problem, there's small gains being made in terms of ending homelessness or providing housing for homeless vets. So I just want to summarize what I think are cross-cutting themes for both those who are chronically and newly homeless. I mean, even though there's some different causes, they're still dealing with some very similar issues. Of course, they're dealing with normal age-related changes. And this is so important to remember because housing providers, homeless shelters, often don't have any staff who have any knowledge of the aging process. And that's not to be critical of them, it's just the reality that they don't have any geriatric expertise in terms of how they interact with someone who may be experiencing visual or hearing impairments or other normal changes. Much more likely to report a chronic medical condition. The most common ones are listed here. And it's important to remember that medical conditions, health problems, they're both risk factors for homeless. They're often a reason, particularly amongst the newly homeless, that someone may end up on the streets because of the costs involved. And health problems are also an outcome of homelessness. And how homelessness exacerbates health problems because of less access to primary care. Homeless older adults are most likely to access care through emergency rooms. They may have problems with managing their medication or adhering to a healthy diet. Again, as I talked to service providers in Seattle, they did comment that managing medication is it's a huge issue for all older adults, but really an issue for homeless adults who they may have it stolen from them in the shelter, they may lose it, they may forget it, and they don't have necessarily someone that's helping remind them to take it. We know higher rates of mental illness, and that's particularly depression and anxiety are the highest forms of mental disorders amongst older homeless, and of cognitive impairment. Social isolation that leads to increased vulnerability. And again, the local service providers talked about concerns regarding safety as being such a big issue for older homeless. They simply feel much more vulnerable, then they're at much higher risk of being a victim of crime, of being injured, of being a victim of violence, and more likely to be ignored by law enforcement. And I want to come back too to not only is it concerns about safety and their vulnerability around being victims of crime, but they simply may not have a place that they feel safe. They may not feel safe in the shelters. Again, shelters, they have to leave in the morning and come back at night. They have no place to go and rest. And that's why we see so many people in public places like the library. And again, for someone who's been ill or who's had surgery or who's had chemotherapy, they don't have a place to go and have respite to really recover from their illness. Another form of vulnerability, weaker immune systems, and if you think about exposure to dampness, extreme temperatures, infections, and older homeless compared to younger homeless are more likely to be negatively affected by shelter rules, particularly leaving the shelter during the day. And then the mortality rate amongst older homeless compared to that of the general older population is actually 3 to 4 times higher. And I earlier said life expectancy is 62 to 64. That was a misstatement. It's actually amongst the chronically homeless 42 to 52. So a very low life expectancy. So what are possible solutions? If we could increase income, would that be a solution? Probably not, because there's so many other factors, but it's important as we're working with older homeless to make sure that they apply for SSI or Social Security Disability Insurance, which is, of course, means tested. 5% of the older homeless are estimated to receive SSI, and that's a very small percentage when you think about that most of them are poor. But even with SSI, they still may fall below the poverty line. And there's barriers to SSI. If any of you have worked with older adults to apply, it's a very time-consuming application process. Immigrants are not eligible. There's a high rate of denial. So many older adults, whether they're homeless or not, may see it as not a viable option. Fortunately, there was an initiative, again, under the current administration to have case managers work specifically to expedite the eligibility process and to try to reduce inefficiencies. And we have seen an increase in the approval rates for those who've been able to participate in the SOAR initiative. Now when we look at barriers and traditional service systems, again, they're often overlooked by traditional providers and particularly vulnerable at hospital discharge, unaware of services or difficulties of navigating and applying, and some are not old enough to qualify for aging network services. And then based on past experiences, distrust of providers, some not wanting to give up their, quote, independence, and fears about institutionalization. So there's a lot of barriers to older homeless accessing traditional services. Again, when I talk to local service providers, they just emphasize that the systems really need to change to be able to be accessible to older homeless. Will anybody in this group add anything to this list of barriers based on your experiences? And some of you are in agencies that you may be able to see barriers in your own agencies. Thinking here, sound generations, the age cutoff, to qualify for services.
Well, it's gone down to 18 now. Taking care of someone, 18-year-olds or two.
That's true. That's true. It's gotten broad.
But I repeat what you said.
I'm sorry, Barb. Thank you. So I was thinking how the aging network services here aren't available to someone who's only in their 50s, but I was reminded that now, because of the merging of disability services with aging services, that someone 18 and older could qualify.
There's still more services for people older.
Right, but there are still more services for people who meet the age 62, but there certainly are some more services now through combining aging and disabilities.
I work with the caregiver, and I've just seen people having to care so much for someone who's going through cancer treatment or just because of dementia. They lose their jobs, they don't have money, then they're in a housing crisis themselves. So it becomes the caregiver could be an adult child and taking care of someone older. That becomes a crisis too.
So the point was just made here, which is an area that we probably will be of increasing concern, is that some caregivers who've had to leave their jobs in order to provide care and may have had limited income to begin with, that the caregiving demands could put them into economic crisis. And when they're freed of the caregiving, they themselves could be certainly precariously housed, if not actually on the streets. And again, to remember that the definition of homelessness includes precariously housed, somebody who's in a temporary arrangement that's not viable long term. Yes, another example of barriers. Yes, please talk about this. This is someone who works with individuals who have cognitive impairments.
So, we often rely on the caregivers to be the report or to initiate or to advocate for the individual, and homeless individuals have no one really to advocate on their behalf, or it's a series of providers that are maybe advocating on their behalf, but it's really challenging for them to enter into that system and have somebody meet their needs.
So the point that's been made about older individuals who are homeless and struggling with cognitive impairments is that so often individuals who are experiencing cognitive limitations have family, friends, providers who advocate for them and help them get some supports. And if you're homeless, if you're in a shelter where there's not even a real recognition of what dementia might be and how to deal with it, you're lacking those supports. Yeah, I mean, I'm just so struck with some of these examples that shelter providers who are amazing for the work they do, but they really don't know much about aging, and certainly they don't know much about dementia. There's an area someone could tackle. So again, barriers to healthcare. We talked about not having a place to rest and recuperate, to get to follow-up appointments. Maybe there's mobility limitations. And then I had earlier mentioned about having medications stolen or lost, and simply the challenges of managing medication. So service providers working with homeless older adults talked repeatedly about there needs to be changes to mainstream programs to be more accessible and appropriate. That outreach needs to be strengthened to reach people where they're at, whether that's a shelter, whether that's a behavioral health clinic. It's not likely to be outreach through traditional medical care. Simplify application procedures, explore ways to help people keep program eligibility even as their housing situation changes. And over and over, people emphasize the importance of integrative approaches, integrative in terms of physical and mental health care. And as the homeless age, this is putting strains on the elder care system. There's efforts underway to how to use Medicaid to pay for services and supportive housing. And the service providers talk to me about healthcare can't always link up with housing and social services, even though there's now greater recognition by healthcare providers that the absolute importance of having housing as part of, quote, overall healthcare. But these are systems that are often overwhelmed, and particularly when we think about trying to deal with the needs of the homeless. So again, how do we get services and healthcare in particular to settings where the homeless are going to be, rather than expecting the homeless to come to traditional settings? So I want to look very briefly at the federal level in terms of policy response. we know that homeless can't be solved solely at the local level. In a 2010 study, only slightly more than 10% of communities were directly addressing the needs of older homeless. In 2011, there was a federal or national effort of convening on elder homelessness, and that certainly led to more recognition of the needs and the importance of looking at ways to change service systems. The only major federal legislative response is the McKinney-Vento Act of 1987. It certainly talked about the diversity of the homeless population, but it did nothing to highlight elder homeless. Within that, there's now projects for assistance in transition from homelessness program, and this does involve care coordination and has been effectively used with older adults in some communities. And then in 2010, President Obama signed the HRSA Act, which expanded the definition of homelessness, again, capturing those who are in temporary situations, put greater emphasis on prevention and much greater emphasis on permanent service-enriched housing. That really has become the mantra as far as solutions to homelessness. And so there's a recognition of the importance of not only permanent housing, but that has services as part of it. But again, we know there's tremendous funding shortages in terms of creating service-enriched housing. And if we look at affordable housing and what exists, Section 202, which is the only program specific to elders, for each available unit of housing under Section 202, there's about 10 seniors on the wait list. If we look at public housing, there's certainly units that have older household members, but public housing typically doesn't have services. It doesn't meet that criteria of service enriched. Although I know in Seattle, some of the public housing is starting to look at ways to partner with service providers and bring services into the independent living units. Section 8, the housing choice vouchers, 21% of those using vouchers are older adults. Again, demand far exceeds supply. So we know that affordable housing is the solution for most homeless, but there's tremendous barriers. Again, some of the problems with project-based Section 8 housing and rural rental housing programs. This certainly is not what we want to see as a solution to affordable housing, but for many older adults on the streets, this is the solution. Now, I've talked a little bit about access to shelters, and in many instances, shelters are not what we would consider age-friendly or a good place to grow old. Not only are they geared to younger homeless, but there's often physical barriers, stairs, standing in lines. There may be barriers in terms of even getting to the shelter. Food programs can't accommodate special diets. Already talked about no access during the day, and the staff with limited gerontological training. Here in Seattle, there's 2 shelters that serve older adults. The St. Martin de Porres shelter is specifically for older homeless men. They have 212 beds. In 2015, they served over 900 individuals, and that's an unduplicated count. Over 900 individuals who were age 50 and older. They turn away about 20 men a night on average. They do have a winter satellite shelter with 34 beds, but even with that satellite shelter, they're still turning away about 20 men a night. And when they turn those men away, there is no place for them to go but the streets. In terms of what's available to older homeless women in Seattle, there's the Lazarus Day Center. It's open from 11 to 6:30. It has space for 350 individuals. So it provides a number of services during the day, and is certainly a place where women can go and can rest and can access a computer, can access showers and laundry facilities. But when I talked to the director of the Lazarus Day Center, she's pushing hard to get the city to provide more funding so it could be open starting at 7 a.m. because 7 is when people have to leave shelters. And she worries about that gap in the morning where there's no place to go. I asked her, well, where do older women go at night? And she said she really doesn't know where older women go at night. And it was just that she really doesn't know how they manage. They certainly go to the referral center in Belltown, but where they go after that, she doesn't have a good understanding. So there seems to be a huge gap in not having a shelter specifically for older women. So again, back to how should services respond, and we know the tangible needs have to be addressed. Getting basic income, it can be a first step, particularly effective with the newly homeless. But as I mentioned, the national mantra is housing first. There's a whole movement called the Housing First movement, and the importance of housing before treatment. And so what the most effective service response is really to help older adults prepare for housing interviews, how to manage housing, and advocate for them in getting housing. In terms of keys for success in working with homeless elders, this is based on national studies, what's made a difference. Again, the importance of housing, but multidisciplinary teams that can understand the specific needs of older homeless, ADA accessible environments, transportation, and close affiliation with a hospital for health care. The importance of coordination across services, help navigating systems and accessing benefits, and case management and continuity of care are really important in trying to move older homeless into a more stable situation. So again, I just tried to summarize what's available in the national literature about what has worked with older homeless. This doesn't mean that all these things are available in any of our one communities, but it's a compilation of what's been found to be effective. And certainly the ideal and standards of care would be that there were healthcare providers were able to do a geriatric assessment. But given the difficulty of accessing traditional healthcare, one worries how often this kind of assessment would be done. Older adults who are homeless are much more likely to have what's termed geriatric syndromes, the incontinence, falls, dementia, failure to thrive, malnutrition, poor health literacy, exposure to the elements, and trauma. And so again, we come back to how to access primary and specialized care and the need for end-of-life care, because that is such a barrier to how can we provide end-of-life care if a person's living on the streets or in a shelter. Establishing rapport and trust is really a big issue in working with the older homeless. And many of them, particularly those who are the chronically homeless, are often referred to as being fiercely independent. It's probably a polite term for stubborn, but that's really an issue that providers have to deal with, and how to motivate people to make changes and to sustain those changes. So I'm going to look very briefly by highlighting some innovations in service-enriched housing from around the country. Again, this is just a sample, but service-enriched or supportive housing, this is a definition that's often given, and it's much more than bricks and mortar, and there's service models that are rooted in cognitive behavior and family systems approaches. And care coordination is really central to service-enriched or supportive housing. Supportive housing can be in a range of settings. It can be apartment buildings primarily for the formerly homeless, mixed-use apartment buildings, rent-subsidized units, or long-term set-aside units designated for special needs tenants. And we have all of these types of permanent supportive housing in the Seattle area. So DESC has about 1,000 units of service-enriched housing, and they again estimate that the average age of the people living in those units is in the mid-50s. They do provide a wide range of supportive services, but again, when I talked to them about the biggest gaps that they saw, they came back to home care and end-of-life care. Compass Housing Alliance is the other major provider of service-enriched housing, and they have one unit that's specifically for older adults, the Angle Lake Court and SeaTac. So those are some models of effective service-enriched housing that are reaching older homeless. But again, when I talk to service providers, this is only begins to address a small percentage, and they see, again, the numbers growing. One of the things that's central to supportive housing is that service use is not a condition of remaining in service-enriched housing, because they found that can be such a barrier if the residents are all required to participate in certain services. So again, it's that approach of housing first, get people into housing. The services are there if they're willing and able to avail themselves, but we really have to deal with the most basic need of providing the bricks and mortars, and then there are substance use and mental health services available, but not make that a condition for staying in the housing. And I think that's been a hard mindset for some providers to adopt. These again are some of the components of service-enriched housing. Again, this would be an ideal model that would have wellness promotion as part of it. Many service-enriched models do not have all these components. There are studies that show that having people in supportive or service-enriched housing results in a decline in institutionalization and emergency room visits and rates of incarceration. It's certainly a less expensive option than nursing home placement. So there's very encouraging results when older homeless adults are moved into service-enriched housing. The first example of service-enriched supportive housing with flexible services was in Boston. It's the Hearth Outreach Program, and they actually provide national leadership. They're the only nonprofit nationally that is specifically for older homeless adults. So I've included their website if you're interested in learning more. They have a very high success rate. It was started by a group of 5 service providers in the 1990s and has been quite successful. This is another successful model in Illinois, where again it's an example of designating a certain percentage of housing units for homeless elders and using Section 8 project-based funding. And in this model, they've concluded that case management services were really the key to success, and case managers who are working very closely with tenants around all aspects of their lives. So again, you've got to have the support for that kind of service, but this has been found an effective model. Again, another model nationally that's often cited for its effectiveness and includes a range of services, including a registered nurse, a medical director who comes from monthly interdisciplinary team meetings, and job training and job search assistance. In San Francisco, the Mission Creek Senior Community is seen as an exemplary model, and it includes an adult day health center. It's interesting, I'm realizing as we're going through these that I've not seen any of the models talk about hospice or home care. But certainly if you're in a setting like this, you could qualify for hospice and home care. But it's not something that's been called out as being available. The rules have to be more flexible. In this example in Boston, that was not the point I wanted to make. I'm sorry. Sorry. Trying to speed up here at the end, and I got lost track of my thought here about what has made this an effective model. This is a model for older homeless vets, and they buy limited equity ownership in the subsidized rental units and a range of on-site services and transportation for services and job interviews. So again, I've included these websites, and this will all be available on the GWEP tonight on their website, so you can download things and find more about some of these models. Now, when housing is not an option, and we talked a little bit about the growing numbers of homeless in Seattle who are living in their cars or buses or vans or trucks, Santa Barbara, with all its wealth, has a safe parking project where they do effectively manage to identify parking lots that create safe outdoor lodging for those who sleep in their vehicles, and they have social workers who visit the lots each night. It's run by a counseling center. In Seattle, the service providers estimate that for someone who's trying to live in their home, on their cars, and wants to have a fairly permanent place to park, that given how long they often move around, it can be 7 years before they have a permanent or safe place to park. So that's a lot of years of moving one's vehicle every night. And even with the importance of having service-enriched housing, there's always going to be the need for shelters. So again, when I've talked to service providers in Seattle, they're saying it would be so great if shelters could move from, they're not just overnight only shelters, but could be 24-hour with some on-site services with comprehensive street outreach. But right now, there isn't a model for that anywhere that I could locate or that anyone knew, but it certainly would begin to address the needs of older adults who really shouldn't be out just on the streets during the day. It's important for all of us to think of being advocates, to push for federal initiatives to increase the supply of subsidized affordable housing. These are some examples where people could try to make policy level changes, where providers have been involved. And again, just some of the things that are going on nationally to try to break down the silos of housing versus services. And of course, the need for more research to better plan and target effective services. So I close with this to give you some suggestions of things that you might be able to get involved in. Here's a list of the national organizations that have been the leaders in trying to look at homelessness amongst older adults. So there would be resources for you to turn to for more information. And I think the primary one I would recommend, if you only had time to read one document, would be the CSH National Convening on Ending Elder Homelessness policy paper. It had lots of examples of model approaches and pointing to directions that one could pursue in the future. Some things that could happen at the state level. Oops. Again, nothing here is currently underway, but they have in Washington State, but it has been effectively done in some other states. And if we think about call to action in Seattle and trying to influence the Seattle City Council, again, the importance of more shelter beds and more hours of the day center, the Lazarus Day Center, settings where older homeless can feel safe, they can let their guard down, they can experience community, dignity, and belonging. Those were themes that local service providers kept coming back to. Importance particularly of experiencing community, dignity, and belonging. Respite for those who are sick, and systems outside of the homeless systems to find resources for marginal populations, because the homeless system is never going to be substantial enough. There has to be coordination with mental health and aging, for example. The homeless system is too overwhelmed to be able to adequately address the needs of homeless elders. And I close with reminding us to always think about the person inside. You know, when we see someone who looks older, and that, again, we may not know how old they are, but if they're living on the streets, they're going to look older than they are physiologically, to think about what life experiences may have brought them to this point. And the service providers I talked with just really wanted to emphasize that, you know, these are people who've been parents, grandparents, some of them are people who made mistakes, but to remember that they're often just like us, fairly ordinary people who've ended up in a place where they thought they'd never be. And I think we all get somewhat immune, I think, to the number of homeless on the streets, but to think about this in particular, and we see an older person. Because in many ways, we're all just one step away from homelessness in our own lives if some kind of crisis or catastrophe hit us. So I've gone through a lot very quickly, and now Barb's going to help me with questions and comments. And Barb, you'll read me the? Okay. Okay, great.
So we had some questions come across while you were talking. The billing VA is asking, would elderly homeless be eligible for Medicaid and a nursing home bed?
Yes, yes, they would be, because if they're Medicaid eligible and are able to find a nursing facility that will accept them, this is where we get into that fierce independence issue. For some older homeless, that's not where they want to be. Of course, for many older adults, it's not where they want to be. And it's also an issue that having someone in a skilled nursing facility is going to be much more expensive for the state than trying to move someone into service-enriched housing. Yes, if Medicaid eligible, they could be eligible. It's whether that is seen as a desirable direction and whether the nursing home is prepared to address some of the distinctive needs.
So someone is asking, and I'm not sure I'm going to capture this right, there may be other reasons for someone being homeless. I think if they have assisted a family member in the last 5 years, have property, the government reg scan can be confusing to use, totally confounding to the homeless. I don't know what that is. Richards?
It would be helpful if the person who raised that question could type us a little bit more about that.
Okay.
Because I'm not sure.
And I think the websites you've already brought up.
Yeah, and again, that last publication that I mentioned, that would be the one, if you could only look at one, that has a lot of other websites in it.
Okay. Any other programs on the horizon for vets? A large number of Vietnam area vets are aging and homeless.
I do not know of any other programs other than the current one with Section 8 vouchers through the VA that, again, has been relatively effective. But this person's question captures the fact that it's not only going to be the Vietnam era vets who are aging and homeless. They're already there on the streets, but we will see 5, 10, 15 years from now, the Middle East vets, the vets from the Middle East wars, homeless. Yes, here's a comment.
And unless you're discharged from a hospital, finding a Medicaid bed in a nursing home is really hard. So, it's like that, and it does cost more money in a nursing home. I don't know what discharge planners do, because sometimes there aren't the Medicaid beds.
There aren't the Medicaid beds.
Places don't want to take them on the Medicaid rates. Adult family homes aren't available, so
Right.
unless you're discharged from a hospital, you've been admitted, it's hard to find places.
So the point being made here is that in terms of the first question, would someone who's homeless and eligible for Medicaid be able to move into a nursing home? And actually someone had pointed out that you need to have a medical reason for being moved into a nursing home. And then there certainly are barriers because the limited number of nursing homes that accept Medicaid eligible persons. So it isn't a viable solution for very many people. it might be a short-term solution for some. Those who've had a surgery or had treatment and need a place to have some rehabilitative care.
So another person is asking if you happen to know of any statistics for Alaska. I'm assuming, you know, that.
I don't, but their state unit on aging might have statistics for the state.
And are there any programs for tribal or Native American populations?
I don't know. I assume there are, and but I don't know. These are good questions.
Yeah. And then a helpful comment, person says, in Missoula, I think they started a HUD-VASH program with the VA. You could also look into whether they have a grant per diem program in Missoula. So I think that's...
Yeah, so that's expanding on the question. The person from Missoula said any other programs on the horizon for vets.
Mm-hmm. Do we have any questions here in the room?
It would seem, in relation to what she was saying about getting placed in the nursing homes, it would seem like a lot of homeless people would likely qualify for some sort of assisted living or whatever they call the level below a nursing home, because I would think a lot of people, I mean, they're capable of living on the street, but maybe not managing their meds and that kind of stuff they need.
But the question or the comment was that another option might be assisted living, but many assisted living facilities don't accept Medicaid eligible.
Medicaid doesn't necessarily get you into assisted living. I mean, I don't know the rules, but my assumption is it probably doesn't.
It doesn't. I mean, it's very rare to find one that will accept people on Medicaid.
But the assisted living places, I think, often have the connection to get you to the next step. If you need it, you know, they'll send you out to the hospital and you get discharged and you qualify for Medicaid, I think. But they have that connection.
Oh, I see your point. So the point this person's making is that, could you repeat that again, that how you see this?
I don't know the system as well as probably most of the people in here, but my assumption is that if you're in a skilled or assisted living system, when you're no longer able to take that, they either have a connection
to get you
real nursing home, or they send you to the hospital, you get discharged, and you qualify for Medicaid at that point.
So, well, your point is that if you're in an assisted living facility and you need skill,
that's more the stepping stone,
right, to skilled nursing.
Bed.
Yes, but I think the real barrier is someone who's precariously housed and low income. I think is very unlikely that they could access assisted living, just because most assisted living facilities are private pay and they're pretty expensive.
I don't know that. I thought there maybe was some sort of public system for that too.
There isn't. Mm-hmm. There isn't.
And waiting lists.
And yes, and long waiting lists. So, while in theory it seems like a good approach, because I'd agree that they might be able to manage in that kind of setting.
And that seems to me like what little I know of homelessness at that age, but you know, certainly some people are able to survive out there on the street, but there's quite a few of them that would probably not do well and, you know, totally independently in housing, but in an assisted living situation, maybe they would do better.
So someone did just type a comment that in Idaho and Washington there is Medicaid eligibility for assisted living. And I know that's the case, but aren't the number of beds very limited? If the person, if Stevens could respond, my understanding in this state is that there's very limited Medicaid eligibility beds.
The housing stock as well.
Yeah. It's under the Medicaid waiver system because they define under the Medicaid waiver system that assisted living is home and community-based care.
It's like several people have had experience with trying to get someone into assisted living, it says.
Yeah.
Right.
Yeah.
So, you know, it takes a long time to get into assisted living. That's certainly true in the Seattle area. But another says there's fewer beds for Medicaid eligible, but you haven't had too much trouble. And so I think it's something to be explored in the different areas, but my understanding is only when they use the Medicaid waiver system that they're able to make that argument that it's part of the continuum of community-based care.
Questions in the room?
Yes.
I'm just wondering, is one of another barrier? I know that kind of generation, some themes that I've heard is maybe a reluctance to accept that kind of help. I'm wondering if you have any experience with that, like a handout. I know it's kind of a generational, at least my experience, and if you've seen that as a barrier.
Oh, I think it's a huge, the question or comment was, with this generation of older adults, and of course we're talking this generation, if we're thinking of the older homeless, is in their 50s, not the, those in their 80s. But are there barriers where they're reluctant to utilize services? And I think it's probably less generational for people in their 50s, but more based on life experiences, that they've had some negative experiences with services, or they feel they have to meet certain restrictions for services that they're unable or unwilling. I think where the generational issue really comes into play is with the oldest old. Those are 75 and older who had a very, very strong value of independence, and if they still are part of the era of the Great Depression, that they carry that with them in terms of attitudes towards services. Other questions or comments? We have someone here who's doing work with homeless with dementia, and you talked about that is a huge gap in terms of supports. Is there anything else you'd want to add for people to think about in terms of how we begin to meet the needs of that population? And I suspect we see dementia at an earlier age amongst the homeless.
We do see it at an earlier age. It's really challenging for those with dementia who get into a housing situation, so say into a transitional housing unit, because they're not able to keep those beds because they lose them due to their cognitive impairment. And so I'm specifically looking at some of the staffing changes and some of the policy changes that could happen to make those individuals more capable to stay in those systems longer.
Okay, so the comment here was, when we think about older homeless who have some form of cognitive impairment, and if they're in transitional housing, they may initially be doing fine, but they're not able to keep it going because they don't have the supports for dealing with their cognitive limitations. So where do they end up?
So unfortunately, from talking with professionals, if you're in a transitional housing, you're not able to follow the rules because of your cognitive impairment, you actually do end up back in the shelter system, which is more chaotic, and you're more vulnerable, more at risk, certainly. So there's not a good fix for that right now.
There isn't. Or if they could, okay. So someone who's cognitively impaired and in transitional housing and unable to follow the rules, unable to function in that setting, is likely to end up back in the shelter system, which is so much more chaotic. I mean, just imagine, it's just hard to even imagine having dementia and functioning in the chaos of a shelter system. Mm-hmm. The noise level, the lighting, the strict hours. And
having to find those shelter beds on your own. And to navigate that. And then they also in turn end up being high users of emergency room services.
Yeah, and that's another good reminder that that where where older homeless persons may end up is in emergency rooms, may have a short-term hospitalization, but then again, they're back out on the street. It's only short-term. This is really, your comments are all really highlighting the gaps, and I think we're only beginning to grapple with it. I mean, as a society, we're still trying to figure out how we address homelessness of all ages. And then when you factor in aging, age-related changes, cognitive impairment, chronic illness, it's just can seem a bit overwhelming.
Wouldn't a responsible hospital, if they were discharging someone with dementia, ensure that they went to a proper facility?
No.
That doesn't happen. I'm asking too much.
So the question was, wouldn't the hospital who's discharging someone, so you're assuming the hospital...
A responsible hospital, I thought they all had social workers and would assure that you got discharged to the right facility.
So the question is, wouldn't a discharge planner make sure that someone gets discharged to the right facility? And I'm sorry if I responded a little
I mean, if you had dementia,
quickly.
I would have thought that they would key into that, and that you couldn't just be put out on the street. But maybe I'm, pretty naive and asking too much.
And do you want to comment to his? Want to respond to his comment?
Yeah, I think it's a good comment, and certainly not naive at all. The folks that I'm working with are in the very early stages of dementia, and so during a brief consultation in an emergency room, often they're not totally aware of what their cognitive capacity is, and they might still be deemed able to make their own decisions and be able to say, no, I don't want that bed that's being offered to me, and can walk away from it. So there's a lot of challenges that make it quite complex for the service provider who's seeing them for just a brief moment in time. That complicates that, and just the amount of beds that are available for that emergent situation.
So again, for those of you who are not here, the issue we've been talking about, and I see some of you are typing away, and that's great, is that if someone's been in the hospital and it comes to the point of discharge, wouldn't the discharge planner make sure they have an appropriate facility to go to? And I responded no very quickly. I want to step back and say discharge planners have very tough jobs, even for people with resources. And so they may be really well-intentioned in trying to do the best, but there's often a shortage of places, as someone has typed. Unless a person has adequate funds or has stayed 3 nights in the hospital, they wouldn't have coverage, and so no long-term care facility will take them. Another says social services should be providing independent living referrals upon discharge, and I would agree with that, but then for someone with cognitive impairment, an independent living referral is not going to be workable long-term. It might be short-term, and then they're right back out again without that as an option. And I think this other was, I hope, somewhat facetious, of a bus ticket to another state where you hope it's better. But yeah, I want to honor and acknowledge your point that yes, discharge planners, they certainly would try to do the best, but there's...
Yeah, I wasn't thinking so much of all the variation in between. I'm thinking of, someone who's truly demented.
So the comment here, they weren't trying to be funny, they've seen, so the discharge planner provides a bus ticket to another state. That's a sad solution, but I can begin to imagine that that certainly would happen in some states.
Maybe a state with more services.
Yes, I think that's an assumption that, yeah.
All right, thank you very, very much.
Well, thank you all. I feel like I'm leaving you with more questions and gaps and unresolved issues, and I hope it, if nothing else, it's increased your awareness and sensitivity, and we start amongst the aging network as well as in the services of shelter